Hey there. Is everyone excited that since we have ice and snow, we get to do the first 2 hours of pre and post-op in this format? I know I am. I want to start out by showing you guys on Blackboard. If you look on here, you've got your pre-post folder, which has your outline, you're used to that, but there is an IV terms and definitions handout on here. You'll notice it says read it thoroughly. This is testable information. The handout has some information on there, especially some terms that you need to learn and become familiar with, like infiltration and things that we're going to use throughout this unit, but also that you have to use as an assessment tool. There will be test questions based on this material, so if you forget to look at it, then you are going to find a couple of test questions where you are completely lost. The next thing is the hazards handout. This is just a little overview. As you get into Med-Surg Clinical, you are now going to become more responsible for IV therapy information. And while you're not fully responsible for IVs just yet, you do need to be able to recognize things that are dangerous. And so that's why we have this handout on there for you to look at. Then, of course, we've got the two PowerPoints. The first one I will be lecturing on today. And then you've also got homework. This Mr. Brown case study is a case study that is going to be due on the last day we meet for class. So that's Tuesday, 24 January at 10 a.m. You are going to need your lab and diagnostics book in order to fill this out and do a good job with that. If you guys have questions on that, I will answer those when we're actually in class. And then last but not least is your drug card assignment. You have 2 drug cards that are due on the highlighted drugs on this particular document. I'm not going to open this document here, but if you open it up, there are a couple of different lists of drug classes, and there are 2 drugs that are highlighted. Those will be due the 25th of January at 8 a.m. I won't take them late, so you either need to have them here at 8 a.m. or they won't be accepted. Okay, so now we're going to get on with the lecture. Now that you understand what your homework is, hopefully you get that. You've got actual homework to turn into me is going to be Mr. Black and the drug cards. The one thing I will say about Mr. Black is that is a very intimidating assignment when you start working on it. I understand that. But what you have to understand is I need you to give it your best effort. Because of that, I don't grade it per se. I will look over it on that day in class, but I don't want you going into the assignment thinking you have to get everything exactly right. I want you to try. I want you to look through that lab book and figure out what you need to know and do your very best effort, because when I come around, you don't know what I'm going to read off of that paper, and if you have not made a very good effort or you've not even tried, you're not going to get the points for it. That's just the way that's going to work out. But if you've tried and maybe not everything is right, you're not going to really lose points for it if it looks like you made a good effort to get it done. So I'll answer more questions on that later if you have any. Okay, let's get started. So this unit is obviously entitled Pre and Post-Op Care, and I'm going to do the first 2 hours in this Camtasia format. Even though you may not be always on a surgical floor, anytime a patient goes off for any type of procedure, even if it's not considered operative in nature, it is still technically a pre-operative type procedure where you're going to do some of the same things to prep them. You're going to do some of the same things when they return to make sure that they're okay. So yes, I am focusing primarily on surgery, but this isn't just for surgery. So let's get started. Historically, surgery became a medical specialty in the mid-19th century. Prior to that, really, a lot of quote-unquote surgery was lucky. If people lived or died, it was a lot about if they were lucky. Early physicians did not understand or value the principles of medical asepsis, let alone surgical asepsis. I mean, medical asepsis is just good old-fashioned hand washing, not even taking into account the fact that if we're going to open a body cavity, we should technically do it in a sterile fashion and only use things that are sterile inside that cavity. They didn't have sterile back then. The best we could hope for was clean, and that's why so many people got infections and so many people died of sepsis. Also, what made it perilous is the anesthesia techniques. A lot of anesthesia techniques involved getting someone so horribly intoxicated that they would kind of just pass out. They were very primitive. You've always heard of biting the bullet or giving them a leather strap to bite on. There wasn't anything that could really put someone into a measured state of unconsciousness until really the 1840s. That was the first time when we started having something that we could somewhat guess how it was going to work. So a lot of times the surgeon's success depended upon speed, how quickly they could get in, fix the problem, and get out. Because otherwise, the patient would either suffer so much pain or so much stress from the situation that it could send them into cardiac arrest, or they would get, a terrible infection from the procedures used. And clearly, they weren't doing these in the most sterile of environments. Half of surgery took place on, kitchen tables and things of that nature. So clearly, we've come a long way since then. Today, surgery is safe. It's life-saving and can promote a better quality of life. Now, I'm saying it's safe because most of the time, it is very safe. But we also have to remember that any time somebody undergoes a surgical procedure, there are always risky aspects of that procedure. Even the safest procedure in the world can still have a little bit of risk associated with it. We need to classify some surgeries and get used to some terminology. So I want to say that surgery can be elective, urgent, or emergent, and we need to understand what the differences are in those terms. I'm going to start with emergency because really this is the type of surgery that is the easiest to understand. Emergency means it is essential for the preservation of life or health, and it must be performed immediately. Usually we are talking about within an hour or at the very most within a couple of hours. But most of the time when we're talking about emergency, we are talking about done as soon as possible. Then we have urgent surgeries. Urgent surgeries are still time sensitive, obviously, but you've got more time. They need to be performed usually within about 3 days to prevent additional health problems or, something bad happening. But again, you've got more time. You don't have to necessarily, run them into the operating room right at that moment. The harder ones are elective surgeries because even though we think it's important for somebody to have it done, they really aren't necessary to preserve life, and time is not a factor. So, for instance, if somebody is having a big problem with their knee and they need to have an arthroscopy and, some surgery done because it's affecting their mobility and their mobility is affecting their life, you would say, well, that's kind of urgent, but really it's not. It is not necessary to preserve their life itself. Now, it may be necessary to preserve quality of life, but that's not a factor here. Elective surgeries are surgeries that aren't to preserve your actual life, and time is not a factor. They could have that knee scope this week, or they could have it a month from now. It's not going to impact their life that significantly, and that's where they're making the distinction. The other distinction is major and minor. I think most everybody, can bend their head around these pretty easily. Major surgeries are things like CABG, a cardio or coronary artery bypass graft, or a major bowel resection or something like that. Minor surgeries tend to be things like carpal tunnel releases, a bunion removal, PE tubes in little kids in their ear, in their tympanic membrane, those are all very minor surgeries. So they're classified as both major or minor and elective, urgent, or emergent. Now, hopefully this slide does get your attention, and I've alluded to this already, but no matter how minor the surgery or how major, all surgery has an element of risk. Clearly, the more major the surgery, the higher the risk, the more elements that can be risky. The more minor the surgery, the fewer there will be. However, any time you are putting somebody under any type of anesthetic, there is always a risk that there will be a bad outcome from that anesthetic. Clearly, 100 years ago, this was far more common. Our anesthetics were flammable, they were unstable, they could be unpredictable, they just didn't behave in a way that could always be guessed at. Whereas these days, the anesthetics that we use have been used so much that we have a ton of information on those anesthetics. And while we still can have patients have things like allergic reactions or some weird reactions, like, we will talk about malignant hyperthermia because it is a weird anesthetic reaction. We will talk about that later. But to be honest, they are truly very few and far between. So while we can't tell a patient there is no risk to the surgery, most of the time the risk is pretty low. And it does come down to balancing risks and benefits. If someone must have a surgery to preserve their life or health, but we also know that they would be an anesthetic risk or a bleeding risk or something like that, we have to decide which one is the least of the two. In other words, which risk is greater rather than the benefit. Because if the patient needs the surgery and they're going to die without the surgery, but they might die because of the surgery, most people are going to take the path of an affirmative act, meaning they'd rather die trying to fix it rather than just waiting for it to inevitably get them. But we will talk about that more as the unit progresses. So the definition of surgery is a process which opens or enters the body to remove, repair, or replace organs or tissue. And perioperative nurses care for patients just before, during, and immediately after surgery. Now, I will say, if you're interested in being an OR nurse, you will have to become an RN because it is part of AORN guidelines that the circulating nurse in the room, which is usually considered the OR nurse, has to be a registered nurse. But that doesn't mean that you're not going to have value in learning about what happens in the operating room. When you're taking care of these people post-op, you really have a much better understanding of what they're feeling and what they're going through if you understand what happens in the operating room. Your clinical instructors will try, whenever the possibility arises, to potentially get you in to see a surgery if they are able to. We can't, we used to just be able to send you guys to the OR for a day. And because of infection control and all of the new JCAHO standards, they just won't allow that. But if you happen to be taking care of a patient who goes to surgery while you're there, you may very well get to follow them to the operating room because that is part of continuity of care, and they allow that. If I had my way, every single one of you would get to see at least one or two surgical procedures because I think it's very valuable for you to see how, even the sterile field and the attention to detail in the surgery for sterility and sterile technique. You think we're picky during checkoffs. You should see what it's like in the operating room. It takes picky to a whole new level. I just wanted to use this slide to remind you about the differences between medical asepsis and surgical. Medical asepsis is what we call clean technique, and we use it when we give meds, when we do any type of procedure that requires, hand washing and wearing clean gloves. So if you're going to come in contact with mucous membranes of a patient, you're going to wear gloves, but you're also going to wash your hands immediately when you take those gloves off. But the number one thing is still just hand washing. Plain soap and water, good friction rub, the whole 9 yards, everything that we taught you back in infection control. But now surgical asepsis is taking that to a whole new level, because surgical asepsis is based on the idea that we are eliminating all pathogens, even spores. So we are trying to make sure that anything that touches the patient is sterile. That means when we're doing something, we have to watch always for the possibility of contamination, and we have to follow all the rules that we learned back in fundamentals about what sterile technique is. It's got to be above your waist. It's got to be within your sight. Anything that's contaminated that touches anything that's sterile, well, that sterile item is now contaminated. The only thing that a sterile item can touch and remain sterile is another sterile item. And if we don't know if something is sterile or not, we have to assume it's contaminated. All of those principles are performed and followed in the operating room in a very strict manner. If you talk to people that work in the operating room, or watch them when they're doing procedures, it's just like they have this innate knowledge of what they can touch and what they can't. That is called sterile consciousness. And you will learn that. You're already learning it now, but you will get really comfortable with that the more procedures that you do. Think about the people that work in the operating room. They spend their entire 8 or 12-hour shift in an environment of sterility. So clearly they get good at it pretty quickly. Okay, so we classified surgeries, but now we're going to talk about the purposes of surgery. Why do people have surgeries? Well, one of the reasons is for diagnostic purposes. We think a patient has something wrong, or we're trying to rule out that it's not wrong, so we remove a piece of tissue or somehow access a piece of tissue, send that tissue off to pathology and study it to determine whether or not it is something that is, benign, okay, it can be left alone, or maybe something malignant. One of the most common examples of this is a breast biopsy. Breast biopsies are one of the most commonly performed diagnostic procedures, and of course, the statistics are that 1 in 5 of breast biopsies result in a malignant diagnosis. So yeah, 80% of the time they get good news, but 20% of the time they don't. Then we have exploratory surgeries. Exploratory surgeries are used to search for a cause of an illness. Like if somebody comes in with abdominal pain, and it's like, okay, my belly hurts. Okay, where? Well, in this area. Well, there might be 3 or 4 organs plus bowel in that area, and we don't know what's causing the pain. We try to do a CT scan, we try to do some other diagnostics, and we can't figure out what the problem is. So now we're down to just literally opening them up and looking around for the reason that they're having the pain. The next type is curative. Curative is, obviously the most satisfying, because this is where we truly fix people. They've got either a cancer that we can remove, and when we remove it, they're cancer-free, or maybe something like a patient with an inflamed appendix or inflamed gallbladder. When we go in and we remove that gallbladder or we remove their appendix, we've taken care of the problem. The problem is now gone. Yes, they still have to recover from it, and they still have, some adjustments for their body to make, but the thing that was making them sick is now gone. And so truly we are curing them. Then next we have palliative. Palliative is not always the easiest to understand, because people will say, well, why would somebody, go through this or do this in this situation if it's not going to cure their cancer? Well, sometimes it's not about, getting a cure. There are certain types of cancer that we know we can't cure, but that cancer causes pain in a particular organ or a particular area that we know that if we remove that organ or do a particular procedure, we will improve that person's quality of life. Palliation is not about curing somebody, it's about making whatever time they have left on earth as good as it can be. And clearly, if you can remove a source of pain, that is going to improve their quality of life. The example I give you on the slide is a urinary diversion. If someone has bladder cancer and it's muscle invasive and they're not a candidate for an ileal conduit or a continent diversion, if they are still trying to use that bladder that is full of cancer, it is going to be a major source of pain. So we might go in and just divert the urine away from the bladder by using, a different type of technique so we can palliate their pain. There's a couple of different ways that works. That's just one example. I'm sure you can think of an example or two as well of different palliative procedures. And then the last is cosmetic. Cosmetic procedures are generally thought to be things that are obviously not necessary. They improve appearance. They make you feel better about yourself. They, take away something that has been maybe causing depression or, giving that person some source of embarrassment. But sometimes cosmetic surgeries also are there to improve function. A lot of people don't think of a cleft lip surgery as a cosmetic surgery, but it is. And if you know anyone who was born with a cleft lip, clearly, getting their mouth around a bottle to suckle or trying to eat as they get older with utensils, it's very difficult if you can't get your lips around that utensil. So even though it is somewhat an appearance thing, it is quite a bit about function, because that's going to change the way they're capable of doing those things. So not all cosmetic surgeries are breast augs. A lot of times it is something that is both a little bit appearance but somewhat function as well. Okay, common surgical risks. Well, bleeding is a no-brainer. If we are cutting into you with a sharp instrument, you got to figure that bleeding could be possible. But some of the other things that people don't immediately think about are things like the breathing difficulties. If we were operating on lungs, it probably wouldn't be difficult to imagine that it could cause breathing issues. But if we're operating on your abdomen, it can still cause breathing issues because abdominal pain makes you not want to take a deep breath. It could set you up for the possibility of post-op pneumonia and cause a whole nother set of problems. Also, most anesthetics that we use a two-part anesthesia most times. An IV part that puts you into a state of anesthesia or unconsciousness, but what keeps you there are gases, usually fluorothane, halothane, desflurane, whatever they're using at that particular moment, doesn't matter, but it is a gas that is breathed in through the lungs. Incidentally, that gas is irritating to the lungs. So you can have some post-op breathing issues just because of the anesthesia. A lot of people don't realize that. Also, the possibility for impaired circulation. Clearly, when we're operating on some area, that area is going to swell. I don't care how good the surgery was or how talented the surgeon is. If you're operating on a limb, especially, that limb is going to swell. If that limb swells too much, it can impair the circulation in that area. You'll be learning about compartment syndrome and all those wonderful things when you get to musculo, but it's definitely something that has to be watched. Immobility is a problem. Now, we think of the global immobility as, just being able to get up and walk around, but I'm also talking about immobility of a particular area. Clearly, if we've operated on, say, your knee, even though you're not going to want to get up and walk around on it, and that's a part of immobility, the knee itself is going to become immobile because of the swelling, and may or may not even require some therapy to regain the mobility needed to continue to walk around. Clearly, most people, I think, are smart enough to realize that pain is also an accompaniment to surgery. One of the biggest mistakes I think we make as nurses is we try to tell patients that because they'll have pain medicine, they won't have any pain. And that's not true. what we need to prepare patients for is pain that can be tolerated and that we can keep it tolerable by using medication. No one should be told that they're going to have a pain-free surgery, because then they're not going to trust you because you're not telling them the truth. What you can say is, yes, there will be pain associated with this, but we will be using various forms of medication to keep your pain at a tolerable level. And then this is a perfect time to teach them about the pain scale and how to use it appropriately, so that when we are trying to gather information about how much pain they're in and what kind of pain medicine we should use, they're already knowledgeable about that pain scale. And last but not least is skin integrity. Now, it is true that we don't always cut into people when we do surgery. Sometimes we enter the body through an orifice or something like that, so there's not necessarily an incision. But most of the time, there is an incision. And anytime you make a new portal of entry into somebody's body, clearly you've got a skin integrity problem. And that also usually goes hand in hand with a risk for infection. Most of the time, we will be very kind of psychotic about our post-op dressings, because we know it takes 24 to 48 hours tops, but it does take that full amount of time for enough epithelialization to happen so that we get at least what I would like to call a cellular seal on that incision. Now, it's not closed by any shape of the imagination, but it's made enough of a seal that it would be very difficult for bacteria to get past it. So what that means is, if we can keep the post-op dressing on the patient for the first 24 to 48 hours without removing it, we have decreased the chance that they would get an infection considerably because of that practice. We know that dressing was put on in a sterile fashion because it was put on in the operating room, in the ultimate area of sterility. So if we can keep that dressing intact and dry and all the things that we like for dressings for that 24 to 48 hours, we have a very good chance of decreasing the risk for infection. Okay, let's start talking about our assessment. Now, some of this I'm going to be tabling until we get a little further down the line, but initially, when we're doing our assessment, I'm going to start with the objective data that we would get. And the very first thing I want to talk about is their lab work. When someone comes in to have surgery, one of the first things I'm going to look at is the lab work that they would have had done. Everyone gets lab work done prior to having surgery, especially if they're going to go under general anesthetic. And we'll talk about who has what, but pretty much every single person is going to get at least a CBC and a Chem 7. So I would be looking at that lab work. Now, I'm not going to go over the lab work right now because we are going to go over that when we do our Mr. Brown exercise on the last day of class. So we will, take care of that at that time. A nutritional assessment might not be the obvious thing to consider when somebody's having surgery. However, you have to think about it. If I want this person to have the best chance possible to heal from this surgery, then they need to have adequate nutrition, adequate protein store, so that when it's time to wound heal, they can do that. So one of the first things I'm going to look at is height and weight. And, a lot of times people want to just ask patients their height and weight. Hey, if you ask me my height, I'm 5'6". And if you ask me my weight, I'm like 118. So neither one of those statements are actually true. So it's very important that you do measure height and weight. And height might not seem that important, but I can tell you that in some urologic surgeries, when we are determining the size of a stent to put in a patient, we calculate it off their height. So if their height is, the height they want it to be rather than the height they really are, you're not going to have accurate data. So most of the time, we just recommend you go ahead and stand them on the scale, get their height, get their weight, and it's all done. I've already talked about lab data a little bit, but we can use lab data to detect signs of malnutrition. We can look at their albumin level. We can look at their red blood cells. If they're low in both of those, that suggests to us that they're perhaps not getting enough protein. Now, we also need to talk about obesity. Obesity is a major factor in decision making for the type of surgery someone has. Obesity adds a considerable amount of technical difficulty to a lot of surgeries, especially laparoscopic surgeries. It's hard for me to make you understand this unless you actually get a chance to see some surgeries, but laparoscopic instruments are basically only as good as the fiber optics inside of them. For instance, when we put a fiber optic lens inside of a person's body, we're relying on that lens to see everything that we can in there. Well, we need that lens to be long enough to be able to be moved around so you can see inside of it. If you imagine blowing up a balloon and using a camera to put down through the opening of that balloon, if the camera can't move at all, then all you're going to see is right in front of you. You need that camera to be able to move around and have enough length to move around and see the different sides of that blown up balloon. If you apply that logic to somebody's abdomen, the more obese they are, then the adipose tissue is thick, and so a lot of that lens is being taken up by just getting through the adipose tissue, and there's not very much lens sitting inside their abdomen that we can move around. Because of that, sometimes procedures that start off being laparoscopic end up turning into an open procedure because of that level of difficulty. Also, obesity does increase respiratory complications. When somebody is morbidly obese and they're laying flat on their back, do you imagine it's easy for them to breathe? Okay, obviously I can't hear you, but I hope you said no. Because clearly, the diaphragm needs to push down in order for them to breathe. Well, when they're laying flat, the abdomen tends to, especially an obtunded abdomen, tends to push upward on that diaphragm, making it more and more difficult for them to breathe. That's why your first job when somebody's having breathing difficulties is to raise the head of bed. You've been hearing that since, 10 minutes into the nursing program. Well, clearly, when you're in the operating room, you can't have the head of bed raised on a lot of surgeries. The patient needs to remain flat so that we have access to the areas that we need to operate on. This sets them up for some additional respiratory complications. And then there's healing complications, because I hope that you also remember that adipose tissue, the fat itself, is not very well vascularized, meaning it doesn't have a lot of capillary circulation. So it's very difficult to get adipose tissue to heal up as quick as other tissue. So if you've got a patient with 1 inch of adipose tissue underneath their skin, they're going to heal a heck of a lot faster than a patient with 4 inches of adipose tissue under that skin. So that's always going to be something that we're watching for and worrying about. Now, when I talked about malnutrition, a lot of people think malnutrition is just, people who are skinny. That is absolutely not true. A patient can be morbidly obese and be terribly malnourished. You have to think about what nutrition really is about. It's not about the number of calories that you get into your body. It's the choices that you make in those calories. If someone is eating, good protein and a lot of different fruits and vegetables and getting a lot of, different vitamins and iron and all of the things that they need, that is the type of balanced nutrition that we're looking for. Unfortunately, in this country, we have become somewhat carbitarians, where we like to get a lot of our fulfilling foods out of carbohydrates, those crunchy foods or starchy foods that make us feel happy and full and all those kinds of things. Unfortunately, they're very low in protein. So patients usually, are honestly lacking in protein in their overall nutrition. Because of that, sometimes you'll see decreased red blood cells, white blood cells, the potential for delayed wound healing, and that increases their potential for injury. Here's why. If you have decreased red blood cells and white blood cells, then we already know we're not having enough protein to make the reds and whites. Well, if you don't have enough protein to make your reds and whites, you won't use enough protein to make a lot of platelets. So if this person, has any type of injury whatsoever, or bumps, or, gets a bruise, they're going to bleed even more. That increases their potential for injury because they're not going to stop bleeding like a normal person would. One of the things we usually recommend patients who are getting ready to have a major surgery do for a week or two prior to the surgery is really increase their intake of protein and vitamin C. And part of the reason for that is obviously the protein, to have more protein available, but vitamin C is very important. Everybody thinks it's about infection control, fighting off infection. It's really not. Vitamin C is very important in establishing the basement membrane in those epithelial cells and allowing them to adhere to the current tissue and then epithelialize across an open wound. So vitamin C plays a major role in that, and having an adequate amount of vitamin C in their body prior to having surgery gives us those stores that we need to start them on, proper wound healing. Now, obviously, along with this kind of general height and weight kind of thing and a nutrition assessment, you're going to do a complete head-to-toe assessment. What you learned back in fundamentals, what you practiced in lab, what you did in fundamentals clinical. You're going to do that again in MedSurg 1 clinical and probably will be checked off on it again. Now, the other data we need to consider ourselves with is the subjective data. And this is again where a lot of nurses make a mistake in rushing the patient. When we interview our patients, we need to allow them to give information at their own pace. If we start hurrying them along, or if we give them the impression that we're just in too big of a hurry to really listen to what they have to say, the problem is the patient will start editing. They will skip over some things because, they just want to give you the highlights. Well, the problem is they might end up skipping over something that's really important that you would have really needed to know about. And there's more reason behind this interview than just information gathering about their disease process. You're also finding out what their teaching needs are. I mean, if you think about it, what are some of the ways I figure out what you know and what you don't know? I don't just start lecturing you, or when I get the opportunity to be in class with you guys when I'm lecturing, a lot of times I'll start a sentence or I'll throw a piece of information out there and I'll start seeing what you guys know about that, because that tells me what your teaching needs are. I don't want to spend my time teaching something you already know, but I want to hone in on what either we don't know or maybe we've learned the wrong way and we need to fix. You're going to do the exact same thing with your patients. You're going to find out what they need to know, and that's where you're going to focus your teaching. You also want to assess for any alterations in their psychosocial function. We assume that every patient is capable of, higher level thinking and the ability to easily translate information that you're talking about into, how it's going to impact their life. And that's just not true. Granted, it is for most people, but there's definitely going to be a percentage of the population that aren't going to immediately be able to get that information figured out. You're going to have to work a lot harder with those patients to help prepare them for surgery. You also may have to deal with some personal perceptions about surgery, which usually are based on previous experience. If somebody has had a horrible surgical experience in their past, or if they've had a family member with a horrible surgical experience in their past, what is their expectation when they come in to have surgery? They are expecting to have a horrible experience. So obviously we want to do something to change that, but it's that perception of what is going to happen that you're going to end up dealing with as a nurse. The next thing that you're going to worry about is the type of surgery. If they're having a very minor surgery or they're having a surgery that's not going to be major league life altering, that's going to be an easier surgery to not only come in and have, but recover from and, basically get back to their regular life with. But if they're having something that's absolutely life altering, for instance, amputating a limb, okay, you've got a surgery to deal with, you've got all the surgical stuff that you would normally talk about, but now you've got lifestyle changes. This is going to change their mobility. It's going to change a lot of the things that they can do. If it's their right leg, is it going to impact their ability to drive? If it's their right arm, are they right-handed? Is it going to impact their ability to do normal things like activities of daily living? You've got to start thinking ahead of what that surgery is going to do to impact their life. And then you also have to take into consideration the circumstances. Clearly, you don't get an opportunity to do this big old nice interview if someone rolls into the ER on a stretcher from a car accident and you've only got minutes before you've got to take them into the operating room because they're bleeding. So clearly, if it's a planned surgery and we've got all this kind of time, we've got a lot of opportunities to get all this information. Sometimes it doesn't work that way. And instead of getting to do pre-op teaching and our assessment in advance, we kind of end up chasing our tail and trying to get a lot of that information after the fact. Obviously, I think you can realize that is not an ideal circumstance. Other things that we want to consider ourselves with in the pre-op assessment are things like health history. I'm looking for things that are going to make this surgery or the recovery from surgery more risky. Age is one of those things. Clearly, as with all things, the very young and the very old are the most at risk. And by very young, usually we really look at kids under the age of 2, but really under the age of 1 as being a surgical or anesthetic risk. If we can avoid surgery during those ages, we do. Sometimes we can't, but they will put off surgeries that don't need to be done until the child is at least 2 or 3 years old because they're far less risky in the world of anesthesia. Obviously, the older the patient is, the more risky it is as well. Now, clearly age isn't everything. Their medical conditions are going to play a big part in that. You can have a 70-year-old with basically no chronic diseases, maybe just a little high blood pressure, and they're going to end up being less of a surgical risk than a 45-year-old with heart disease, diabetes, and a laundry list of peripheral vascular disease and all this other kind of stuff. That 40-year-old is going to be a nightmare compared to the 70-year-old. Also, we have to consider allergies. Not just drug allergies. Everybody just immediately goes, oh, drug allergies. Well, what about latex allergies? What about tape allergies? What about, it's rare, but what about allergies to suture material? These are all things that can happen, not very often, but you still got to have them in your mind as things that can occur. And then that patient's habits. I cannot begin to tell you how big of a problem smoking is when we're talking about surgery. Smoking does so many things to a person. I don't even have time to go through all of that. But the issue is smoking affects the lungs, and anesthesia is all about the lungs. Yes, we're going to use an IV anesthetic to induce you into that anesthetic state, but we are going to keep you in that anesthetic state with anesthetic gases. That is going to severely increase the risk of respiratory complications post-op. Most smokers are already a higher anesthetic risk just because they're smokers. And then obviously alcohol and drug use. I mean, clearly if a patient will be honest with you and tell you, you at least have the information, but using and abusing alcohol and drugs can impact the way anesthesia or pain medicine works for them, and it can, change their outcomes. Clearly, if somebody is an alcoholic and they're not telling you 2 or 3 days after being without alcohol what's going to happen, they're going to start going into DTs and all this other kind of stuff. I will say that a lot of times when somebody is about to go under the knife, they will tell you the truth, but most times patients skirt over the truth. They don't want to tell you everything, and you find out sometimes the hard way that they weren't completely open with you during the assessment. Clearly, medications that the patient takes can be impactful also. If a patient is on any type of anticoagulant, especially oral anticoagulant because they have a much longer half-life and they take a while to get off of, they're going to have to go off of those before surgery. So, we're obviously worried about the bleeding risk, but then when they go off of them, we're also worrying about clotting. Patients who are diabetic, oftentimes take hypoglycemics. Now, if they're taking insulin, that really doesn't impact us too much surgically. But if they're taking oral hypoglycemics, some of them cannot even be taken and have anesthetic, and others, because of their method of action, you can't use the oral hypoglycemics prior to surgery, so you have to switch them over to insulin. Then that stresses the patient out because they start thinking, oh, I'm going to always have to be on insulin. They're not. But to get us through the surgical time frame, sometimes we have to do that. And then, of course, what's really, horrible is if they've had any type of anti-neoplastics recently. Sometimes we'll give patients chemotherapy to decrease the size of a tumor before we try to go in and take it out. And while that's a great idea for the tumor, and it's a great way to treat cancer, it really diminishes our ability to get them to wound heal after the surgery. Because what does anti-neoplastic medication do? You probably don't know this yet, so I'll tell you, but it basically attacks any cell in the body that is fast growing. That's why it attacks hair and the lining of the GI tract. But what else is fast growing? The epithelial cells that are going across that wound. So if they have to take anti-neoplastics, we're hoping to have a big enough gap between when they last had a dose and when we do the surgery so that we won't have a terrible delay in the wound healing. Now, other things that we think about when we're doing our assessment is, there are considerations for our elderly patients. A lot of times when your elderly person comes in for surgery and you start asking them what medications they take, they just pull up this massive Walmart sack with all these bottles that are just thrown in there, and they'll slap it up on the counter and say, I take this. Well, what is the chance that some of the medications in that Walmart sack are, creating side effects or interactions with other medications? And then what's the chance that one of those medications could interact with something that we're giving them in surgery? So clearly, the increased number and types of meds that the patient takes when they're older increases the risk that we're going to have complications from medication interactions or medication problems. Also, elderly people tend to have an increased number of chronic illnesses. You're going to see this more, when you get into med-surg, but even at the nursing home. If you looked at your patient's laundry list of illnesses that they were in that nursing home with, very few of them were in there with one or two. They had 6, 7, or 8 of them. The longer we live, it seems like the more we add to our list. Also, for elderly folks, it takes longer for them to regain their strength after their times of immobility. So whereas that 30-year-old is going to hop right up after surgery and be able to maybe not do a jig, but certainly walk down the hallway without too much difficulty, it might take a lot of effort to get that gerund out of the bed and walking even a few steps in the room. And you may have to do that several times before they can ever walk down the hall. Also, if you have a 30-year-old come in for a gallbladder, you already know when you discharge that 30-year-old, more than likely, they're just going home to their family. But when you have an 80-year-old come in for some type of procedure and they live alone, they don't have anyone living generally right there or nearby, well, is it safe to send them home? Are you going to have to send them to a facility? Are you going to send them to, one of their family members' homes for a couple weeks? Are you going to have to send them to a rehab facility or a nursing home? Then, for your pediatrics, the thing about the operating room is there's a crap ton of stuff in there that even adults would find a little scary. Clearly, children get really frightened and upset. Even the O2 mask or some of the equipment or even the clothing that we wear can oftentimes frighten a kid. I always made it a habit when I walked out to talk to a pediatric patient this was kind of maybe scary in and of itself because God knows what my hair looked by that point in the day. But I took my OR cap off and my mask off completely. And when I went up to the child and greeted the child, I let them see my face and talk to him for a couple of minutes just letting them see my face, letting them hear my voice. Then when it was time to get ready to go back to the operating room, in front of them, while they watched, I put on my hat, and then I put on my mask. And then I kept talking to them for a couple more minutes so they would get that idea that even though now I'm wearing a mask and a hat, I'm still the same person. I always made sure I did that with kids because, we cannot wear our mask, we cannot wear our cap, but if we give them that chance to see us and make sure they know us before we put it all on, that does help diminish some of their, fear. Okay, I'm going to stop the recording here. This is what I would normally do in class. We're about 50 minutes into the lecture, and I'm going to stop this recording, and then I'll start it back up here in just a few minutes.